Welcome to Modern Minds. I'm Mark Hennick. Today we're going to be talking about involuntary hospitalization, and my guests are Dr. Awais Aftab and Dr. Puri. So let's get to it. Welcome to Modern Minds. I'm Mark Hennick. Last fall, the World Health Organization reaffirmed its position that mental health is a basic human right for all people. Now, they define their human rights perspective on mental health to mean the right to available, accessible, acceptable, and good quality care, as well as the right to liberty, independence, inclusion in the community. Meanwhile, involuntary hospitalization and treatment has been more or less a mainstay of mental health care in America for generations. The advocacy group Mental Health America has stated that involuntary treatment, though, should only occur as a last resort, and it should be in limited to instances where a person poses a serious risk of physical harm to themselves or others in the near future, and limited to circumstances where no less restrictive alternative will respond adequately to the risk. Now, the question that we're asking in this episode of Modern Minds is whether or not this tension between human rights and the safety of both the person and the community can ever be resolved. I'm joined today by two distinguished guests to explore this issue. First up, Dr. Awais Aftab is a psychiatrist in Cleveland, Ohio. He's also a clinical assistant professor of psychiatry at Case Western Reserve University. He's a prolific writer on the philosophical issues in psychiatry, and he's the editor of Conversations in Critical Psychiatry, which was published by Oxford University Press. Dr. Aftab, thank you so much for joining us on Modern Minds today.
Thanks so much for having me.
So, first of all, I want to get a better understanding of the use of involuntary treatment in America. Most hospital settings that I'm aware of, they seem to use it to some degree, maybe even more so than most people realize. I'm not sure. So, maybe can you cast that for us? What is your sense of the prevalence of involuntary treatment for mental illness, especially as opposed to voluntary or willing treatment?
Certainly. So involuntary psychiatric care is it's practiced across America and across the world. And am I in fact not aware of any geographical region in the world that has fully eliminated the use of involuntary care? There are systems that have minimized it to a great degree, but no one has successfully eliminated that. In the U.S., involuntary care is largely practiced in inpatient psychiatric units. And right now, the situation is that in the beginning, most patients get admitted to inpatient psychiatric units on an involuntary basis, at least on paper. Subsequently, they may switch their status to voluntary, or they may be discharged after a short period. But in the beginning, most people get admitted uh, technically on a psychiatric hold, and then most people after a certain period of time either get discharged or they turn into voluntary status. And then it's a small percentage. It's difficult to say for sure because we don't have exact figures. This data is not widely available, but if I had to guess, I would say probably 20 to 30% of people or less go on to full commitment. That is, they have to appear in front of a court where a judge has to hear the case and issue an order of commitment.
And we'll learn a little bit more about the legalities around this later in this episode, but I understand that it would probably vary at least to some degree, maybe even drastically from jurisdiction to jurisdiction. But I do want to zoom in a little bit more closely on the clinical application of involuntary hospitalization here, because you mentioned that that happens when people come in, especially if they're presenting a risk. So take me through that process. You're sitting across from a patient. What are you looking for? What's going through your mind as a clinician when making a decision that I think most would agree is fairly drastic to hospitalize somebody against their will?
Yeah. The most common pathway to getting admitted to an inpatient psychiatric unit, especially involuntarily, is through the emergency room. So people reach the emergency room through a wide variety of ways. They may bring themselves in. Their family may bring them to the to the emergency room with some concerns, or in many cases, the police might be involved, and they may bring the person to the emergency room. In the emergency room, they're typically evaluated by a physician. Uh, Sometimes, in many emergency rooms, if there is access to psychiatrists, they would be evaluated by a psychiatrist. But in many ERs, don't have access to psychiatrists, so they may be evaluated by a social worker or a psychologist who is trained in these evaluations. Once that evaluation happens and a determination is made that the person requires inpatient psychiatric care, or they require involuntary inpatient psychiatric care, then they are transported to a psychiatric hospital or a psychiatric unit on a hold. The main considerations that are going into that evaluation in the emergency context, they're along a few lines. The first is considerations of risk. And these are along the lines of risk of suicide. Has the person attempted suicide? Are they saying that they're suicidal and they're going to harm themselves? Have they expressed such things to the family, and the family is really worried about their safety? Or are they violent? Have they, perhaps they're psychotic or they're manic? They have attacked someone. They have exhibited, aggression that cannot be managed in the community. So there are these considerations of risk. Then there are considerations of disability. For example, in cases of dementia or cognitive impairment or severe cases of psychosis, where the person is unable to care for themselves. They are so impaired that they cannot ensure that they have access to food, access to shelter, other aspects of safety. So disability is the kind of like the second thing. And then in many jurisdictions, there's also consideration of behavioral disturbance that poses a risk to public safety or otherwise impinges on the well-being of the person. So, for example, if someone is very, very psychotic, very manic, or very delusional, and they don't recognize that, and they're acting in ways that is posing a problem for them, or for their family, or for the community, then those cases also get considered for involuntary psychiatric care as well.
You mentioned earlier some of the limitations around data, which is, a little bit shocking to me that we wouldn't. I mean, they probably do, or whoever they is, track these sorts of things. But I'm curious about, especially since this is a question that might come up in the mind of the average person, what would you say is the ratio between people who present risk of harm to themselves, who present to an emergency room or law enforcement, or whatever pathway they come into involuntary treatment? What would be the ratio between people who present risk of harm to themselves versus risk to somebody else?
It varies a great deal. It varies a great deal depending on the setting, the geographical region, the sort of inpatient unit. In general, sort of like my general impression these days is that majority of people tend to present either with some form of suicidality, or some form of sort of like behavioral kind of aggression or disturbance. And then there's a somewhat smaller group of people who are experiencing severe mental illness, and they are floridly psychotic or floridly manic. That ratio changes in more disadvantaged areas, and in places like state hospital, for example, you would see a much greater proportion of people with serious mental illness. But if you're looking at, for example, at academic university, hospital setting, we might see a lot more people experiencing depression, suicidality, mood disturbance, etc.
Hmm. From a clinical perspective, what do you think involuntary hospitalization can actually accomplish that voluntary hospitalization can't? Is it just the safety piece, or are there any potential clinical benefits there?
So the priority of clinicians is always that if the person is willing to receive treatment by their own volition, then people go with that. So as I mentioned, in the beginning, most people start their admission on a psychiatric hold. But if they're willing to be there, and if they're willing to work with their treatment team, their status gets rapidly switched to voluntary. So people who want to get voluntary care, there most of them are able to do so. Um, people who receive involuntary care are primarily those people who don't recognize that they are disabled or impaired, or there is some consideration of risk, and and they're not aware of that. They don't appreciate it in the same kind of manner, and they're not willing to stay in the hospital, and they're not willing to work with their treatment providers in coming up with a plan for management, and coming up with a plan for where they're going to go. So those are the cases that are truly involuntary, where there's a disagreement between what the patient wants and what the treatment team, and often what the community and the family of the patient wants, and those cases then proceed on to cases of kind of commitment hearings in the court.
Mm,
And in terms of like what it can accomplish, the main thing we're trying to do is that get the person out of that acute state of crisis. So if they're experiencing psychosis, the goal is to either resolve the state of psychosis or improve it to such a degree that it can be managed outside. Or if they're manic, the goal is to bring their mania down to a level that they can be safely discharged.
sure. Well, and the reason why I ask about the potential benefits or clinical upside of involuntary hospitalization is because I'm also interested in the other side of this here. Is there any data or at least anecdotal sort of evidence that sort of decision on behalf of a healthcare provider can negatively impact the connection between the client and the provider? The can it actually raise the risk of resistance and complicate their treatment going through that kind of process?
Yes, it's any time a decision to involuntarily admit or involuntarily treat a patient, there's a complex trade-off here. There are advantages and disadvantages. The disadvantage, as you managed, is that we are overriding the wishes of the patient. We're disrupting the therapeutic relationship. We're potentially putting them in a situation where they might, experience distress, where they might experience the whole incident as being very traumatic. And in fact, there is a subset of patients who find the whole experience very traumatic, and their view of healthcare and their relationship with healthcare is altered forever. So there are definite risks, and in addition to the fact that the person's life has been disrupted, that while they're in the hospital, they cannot go to work, they cannot be with their family. The But then there are advantages, and the advantages is that severe states of mental illness, they pose risks of their own. Um, People in severe states of psychosis or mania or depression, they're unable to function in their daily life. Their behavior gets very very disturbed. They may lose their jobs, for example. They may lose their housing. They may end up homeless. They may get into trouble with the police. And this is partly why we see such high rates of mental illness in people who are homeless, people who are in jails, people who are in prison. Is that when people don't receive mental health treatment, then they get into trouble in other ways, and society find other ways of containing them. Whether it is jail or prison, or whether it is some form of neglect such as homelessness. So it becomes this terrible choice, is that we have to do something that takes autonomy away from the person. But we also don't want them to be in a position where they are vulnerable to that kind of harm to themselves. So it's a difficult choice, and there's always going to be this tension, and it cannot be fully resolved. It can only be negotiated, and we have to find the best balance that we can between the two. And
Mm,
it helps. The more opportunities for mental health care we have in the community, the less we have to rely on involuntary inpatient care. If people can easily access mental health care in the community, if they can easily see a psychiatrist, if they can easily see a psychologist, if they're in a state of crisis, they can easily receive crisis care outside the hospitals, then we wouldn't have to rely on involuntary care as much. And this is what some of the countries, such as, for example, Trieste in Italy, has done. In US, uh, community mental health care is severely neglected. Most states do not have adequate resources, or they have not allocated enough resources and funds for community mental health care. So, given this impoverished state of community mental health care, there is more reliance on the use of involuntary inpatient care.
Hmm. I want to address two important points that you meant here that you mentioned here rather. One, to help somebody who's vulnerable, where the impacts could be much worse. You've had a lot of conversations in critical psychiatry, as I mentioned at the top, and it's a conversation, I think, anyway, within the critical psychiatry community of practice, if you could call it that, around paternalism in medicine and psychiatry in particular. Is there a strain of paternalism in saying we're going to treat you because it's in your own, because it's for your own good, and maybe you'll thank us later, kind of thing? Not putting it that way, but is that sort of a hint of that here?
There's certainly there's an element of paternalism, and it's not specific to psychiatry. It happens across medicine. Anytime we're in a position where the person, their mental faculties have been affected in some way. So, for example, in ICU, for example, many people experience delirium. Their thinking gets clouded. They're confused. They don't know where they are, they often try to leave, and they often resist the care they're receiving. In ICU settings, often these patients have to be treated against their express wishes, because they're so floridly confused in that moment. It happens in cases of dementia, where people's memories and their thinking is affected to such a degree that they don't recognize that they're so impaired, and in order to help them, we have to override their wishes. So similar kind of problems come up in psychiatry as well, when people experience mania, when people experience psychosis. They lack understanding and appreciation of the changes that they're undergoing. So the paternalism comes in necessarily when the person is in a vulnerable state, and when the person is not in a position where they can make sensible or reasonable decisions, about their own healthcare. This is where, things like, input from family, input from guardians, or even things like advanced directives can be very useful, where when people, they're of sound mind, they can put into writing as to, like, how they would like to be treated, if they were to experience a mental health crisis, for example. Um, so there's an element of paternalism for sure, but it's difficult to eliminate, as I mentioned, when a person's, thinking is affected to such a profound degree and they're in this vulnerable state.
Now, you also talked about the lack of effective community treatment. To go back to that Mental Health America statement that I mentioned at the top, there are less restrictive means that maybe could bridge the gap between involuntary inpatient care and lack of community care, leaving people to their own devices. And I'm thinking specifically of day hospital programs, or here in my jurisdiction, we have what are called assertive community treatment, or compelled community treatment. Are these sorts of models an effective bridge that can accomplish the same benefits without some of the drawbacks?
Yes, yeah, I think there's so much we could be doing more. For example, we can have a lot more crisis stabilization units. These are places where, when people are experiencing some sort of mental health crisis, let's say they're very depressed, perhaps they're experiencing thoughts of suicide. They can go to that place, they can get admitted, they can stay there. These are usually not locked places. Inpatient psychiatric hospitals are typically locked, where crisis stabilization units are not. So they offer a more flexible, way of addressing the needs of people, with less overriding of autonomy, and less distress. Similarly, many people could, in principle, be treated at their own homes. If we had teams of people who could visit people where they live, and they could, let's say, in a state of crisis, they're visiting them every day, they're modifying their medications, and they're making sure that the person is safe, then many people who are now being admitted in psychiatric hospitals, they could be managed at the home. The idea is called home hospitalization. Certain jurisdictions in Canada, for example, have tried it out. We don't really have that model in the US, with the exception of the ACT team that you mentioned. And in cases where ACT teams are involved, these are usually people who have had repeated hospitalizations. ACT teams have been shown to reduce the risk of future hospitalization. So we know that there's a lot more we could be doing in the community. One issue is that even the simple fact of, if you're experiencing mental health symptoms and you want to get help, it is very difficult to find an outpatient psychiatrist who has an opening. It's very difficult to find a psychologist who takes your insurance and who has an opening. So many people end up coming to emergency room simply by virtue of the fact that there's no provider in the community who can see them in a timely fashion. So if we are really interested in reducing our reliance on involuntary care, we have to pour a lot of resources into community, and we have to build these kind of transitional programs that can provide the sort of services that people need in a crisis.
We're running out of time, so I want to just fit in one more question here before I let you go, Dr. Aftab. Um, it seems like these sorts of treatment options and the history of psychiatry and of mental health more broadly ebbs and flows. The pendulum swings in both directions in terms of hospitalization and the asylum age, and then after Kennedy and the closing down of the asylums, to an apparent entire lack or near entire lack of effective community treatment. Is the pendulum swinging back now toward more of a hospital-based version of mental health care, or are we finding sort of a more harmonized, integrated version of healthcare between hospitals and community services?
I think what we are seeing is that there's a lot of discussion going on, and these discussions have attracted some political attention as well. And I think people have become frustrated with the lack of community resources, and in that state of frustration, they're thinking what can be done. And so certain states, for example, such as New York and California, the politicians there have become interested in, can we rely more on involuntary psychiatric care as a way of addressing some of these issues with, for example, with homelessness, and other concerns about public safety that they're experiencing. I personally don't think that is the right way to think about it. I think the long term solutions are going to come from investing in community care and by building resources that people need in the community. We won't be able to eliminate involuntary care. There's always going to be a small percentage of people who cannot be managed in the community, but we should try to keep that percentage as low as possible. But because it is very difficult to build these resources in the community, I think there's a state of despair, about inability of our political system to provide those sorts of resources. And I think so. This turn towards involuntary care, this turn towards expansion of involuntary care that we are seeing in certain states, I think it is born out of that frustration.
Hmm. Dr. Awais Aftab, we have to leave it there. Psychiatrist in Cleveland, Ohio. Your Substack is Psychiatry in the Margins. Thank you so much for joining me on Modern Minds today.
Thank you.
We'll be right back with more Modern Minds right after this.
Mental health is health. At the Institute of Living, we are pioneers in mental health, and we have been for 200 years. We have an ambition to transform mental health services while co-designing these services with those whom we serve. Together, we can reduce stigma, address discrimination, and increase access to care.
Welcome back to Modern Minds. I'm Mark Hennick. My next guest is Dr. Paul Puri. He's a psychiatrist and clinical assistant professor at UCLA, and he's also a television writer. He's worked as a staff writer and executive story editor for Chicago Med on NBC. Dr. Puri joins me now from Los Angeles. Paul, thanks for being here.
Of course. Thanks for having me.
So we're exploring on this episode today the concept of involuntary hospitalization. Now, I spoke with another guest a bit about what's involved with that sort of clinically in those kinds of situations. Most people probably present with some sort of risk of harm to themselves or to others, or maybe a variety of other criteria depending on the jurisdiction. But I'm interested in tapping into alternative approaches with you today and unpacking what those might look like. Whether that's
Mm.
before someone even shows up to a hospital or crisis situation, or maybe during or after to prevent readmission. So let's start at the start here. Uh, I'm going to make a guess, and I want you to correct me if your clinical experience and your professional experience has been any different. But would it be accurate to say that a sizable portion of people who are hospitalized involuntarily are likely to have had some sort of prior connection with mental health services, whether prior hospitalizations or sort of precursor type treatments? Would that be fair to say?
Um, I would say a majority, as in more than 50%, but I would not
Okay.
say like a predominant amount, like more than 90%. There are
Oh,
a large number of people who get brought into the hospital who are there for essentially like a one-off. They get
yeah.
brought in by the police once, they get brought in by family once, and then to maybe some of the points of this talk and discussion, they get so turned off by their experience they never want to go back again. So they do everything they can to avoid being anywhere near a hospital.
Interesting. Okay, so let's look at both of those cases then. In that case, um, to avoid the so-called revolving door, I think that we can often
Mhm.
see in inpatient mental health care. What do you think needs to be in place to help people with high need, people with recurring mental illnesses? What needs to be in place to help them stay out of hospital, if that's indeed the goal?
Yeah, I used to do work with a what we called the IMHT, which is the Integrated Mobile Health Team. It was a homeless service wraparound care, where basically we had a multidisciplinary team of essentially clinicians, social workers, case managers, psychologists, and even family medicine doctors to deal with medical issues. And really, I think it's about serving the diverse needs, and that might be about essentially plugging them into a social network. It might be about occupational needs, but trying to actually customize and address issues more broadly than we do in traditional clinical mental health care.
So now I don't want to forget about some of the first timers that you mentioned as well, those one-off type experiences. I
Sure.
imagine those can be incredibly hard to identify, but what do you think needs to be in place in those kind of circumstances to intervene before it gets to that critical stage where they might be perhaps a danger to themselves or others?
Yeah, I mean, I think the first pass is identifying people who are truly high risk. So there are people who are brought in who are essentially doing something that is more kind of danger adjacent. So they're cutting on themselves. They are they might be thinking about suicide, but it's very, light thoughts. But what you end up having is clinicians who are less familiar with essentially like suicide risk assessment. And so they might still send them to get at least evaluated. And those people may or may not end up in the hospital. It depends on various factors, family pressures, insurance, bed availability, things like that. But that's sort of a first group that don't necessarily need or even benefit from hospitalization. The second group is really about preventative care. How can we get people into some level of care connected to resources earlier in kind of a preventative model, as opposed to waiting until people reach a crisis level before intervening? We do that all the time because we don't want to get in people's business, because we allow for people to make their own choices. And a lot of times people, frankly, avoid aspects of taking care of themselves until they're really falling apart.
That's so true. I mean, either way, if it came out of nowhere, I don't believe that any of these situations really ever truly come out of nowhere. But that's what it can feel
Yeah.
like, either to some people or their families. So either in those cases, or for the people who have been to this rodeo a few times, every day
Mhm.
people present to hospital emergency rooms, whether that's through police services, like you mentioned, or primary care providers. Even teachers and community workers might be the ones who bring people in and think that they might need hospitalizations. So then, what do you think are
Yeah.
the alternatives in that moment? Before the or after the prevention stuff, but before the hospitalization. So somebody comes into the hospital. Is it then
Mhm.
necessary to trigger this process of hospital admission, either voluntary or involuntary? And are there other alternatives when somebody presents in that way?
Well, I think we have to really examine more deeply, Mark, like what does a hospital actually do?
Hmm.
For the most part, because of bed shortages, insurance reimbursement rates, most hospitals don't do a lot more than kind of create a holding environment. They'll, maintain a watchful eye and some degree of safety. They may adjust medications. They'll have some group therapy, and it's very mixed on whether someone actually benefits from that or not. You'll see people who will be talking about something for the first time. Maybe they've never talked about it before. That does have a benefit, but is it necessary to be in a hospital for that? And I would say that it's a mixed bag. You don't actually know. I think that at least trying some other levels of more aggressive outpatient treatment is worthwhile if possible and if safe. It's always up to the clinician, the circumstance, to try to evaluate, is this person safe to be out of the hospital? Can they be at home? And frankly, a lot of what I see a lot, I had to hospitalize somebody recently, is family members who are just burned out. They're exhausted and they need some type of respite. The hospital isn't a perfect fit, but it gives them some type of benefit in that way. And
Sure.
so,
I'm
yeah,
I think you hear all the time as well that people struggle to either afford or to access services in their communities that are not hospital based. So they'll come into emergency rooms, or they'll go through police or some other method, because that's the only way they think, anyway, that they can get services. Is that the case, in
yeah.
fact?
Yeah, I mean, I think it depends on the locale. I think in certain areas, police services, emergency services, 911 can be used or even abused for access to services, because when someone comes into the hospital, they have to get evaluated legally, at least in the United States. Um, so people can use and abuse the system in that way. Alternatively, like anybody can come in to get evaluated otherwise and probably access other services, but it's an incredibly fragmented system. Most people don't know how to access the services that are available. And if you're not in a well-funded part of the country where county or available public services are available, then there's really, the options are really narrow. And even here, the options for outpatient treatment, for group therapy, you've really got to shop around and try to and take some time and shoe leather to try to navigate it.
Hmm. I've seen other models that aren't just your usual sort of locked ward, which is typically,
Yeah,
or it seems to be very often the case, especially if somebody's involuntary. But day hospital programs, partial hospitalizations, that sort of model, they
yeah,
seem to have good results. Is that something that is implemented regularly, or are those just sort of one-off research
yeah.
projects, basically?
Yeah, no, they're very available. So you have PHPs, which are partial hospitalization programs, IOPs, which are intensive outpatient programs, and then for people with severe mental illness who are frequent users or have high needs within the system, sometimes what you have is again sort of a wraparound team. They have which is essentially an clinician, case manager, sometimes psychiatrist, who will either go and visit the person and do home visits, or sometimes like arrange transport for them. And they have a whole team dedicated to them, because it's cheaper still to do all of that than to bring them into that revolving door of the hospital. So all of
Mhm.
those are options, and sometimes actually more cost prohibitive, more cost advantageous for the system than trying to manage these things in the hospital. Because again, hospitals are just not well equipped to handle chronic and longer term issues. They're really there for just acute stabilization these days, which is
Mm.
unfortunate.
We hear a lot in the news, unfortunately, I think, about things like conservatorships and guardianships. Can you walk us through that process a little bit? Because it does seem to have a similar kind of compelling of treatment and limitations on civil liberties without necessarily
Yeah.
putting you in a psychiatric hospital.
Yeah, so I'll speak about it in California, and every state has their own laws about this, which are a little bit different. Some err more on the side of individual rights, and some err more on the side of states' rights. But essentially, someone has to have had a pattern of not being able to take care of themselves in some ways. In the state of California, we call that grave disability, which means inability to manage food, shelter, or clothing due to a mental illness. And that usually gets evidenced by repeated hospitalizations um, over and over again, and not really learning or taking advantage of the care that's there, and not making good decisions for oneself, which sounds a little broad, I know. But if you have someone who can't maintain their housing because they won't stay on their medications, they won't seek out services, and they're psychotic, they have ongoing hallucinations or paranoia. Maybe they've been aggressive, but usually conservatorship doesn't go for that. So eventually, someone will apply for a conservatorship, which is basically um, having someone's rights taken away for a year, where someone gets appointed, usually in the county, to be a surrogate decision maker for them, and they get to decide when they go in the hospital or don't. And then other sort of aspects of that get decided by a judge, assuming a judge approves it. But essentially, they go to court, they have a lawyer, a doctor testifies on the behalf of the hospital or whoever applied for it. And then basically the judge rules, do they agree with that? And they want to take away the rights for a year and pass it to the surrogate decision maker. And what other rights should be taken away from them? Ability to own a gun, ability to vote. These things are sort of steps in the decision making process, and all of that's decided by a judge. And then it gets renewed or reevaluated on an annual basis.
So, given that is the goal in a conservatorship, or and maybe more pointedly back to what we're talking about here, hospitalization, is the goal still recovery to get the person back into their own ability to make decisions for themselves?
Yes. I mean, it's similar to in the forensic context of like restoring competency for someone who's incompetent to stand trial. The idea is getting better compliance or adherence to care, and that in that context, there will hopefully be recovery and improvement. So that might be getting them to go along with long-acting injectable antipsychotic medications, which would get injected into their arm or their butt, basically, or hip, and with the hope that that would improve outcomes, and then they won't end up in the hospital so often.
I noticed though that you were a bit hesitant maybe in answering that. So, how often does that actually happen?
Well, I was hesitant because the entire system is frankly like disorganized, and so much of it functions in crisis mode. How do we deal with the acute problem right in front of us? And the idea and the focus or orientation around recovery, I don't know, sometimes can get lost in it all, which is sad. But I think that that's part of the issue and part of my hesitation. So I think we all want recovery, but sometimes we just focus on, okay, what can we do to? When I used to work in hospitals, how do we get the person improved enough to get them discharged, or how do we get them compliant enough to take this medication with the hope that this will work? Or if it's about, we can talk about substance abuse or substance use disorders. How do we get somebody to a meeting as like a start, or just that first small step, with the hope that these things chain together into a longer term trend of improvement. But it's a hard game, and often there's, I don't know why I'm using a sports analogy, but there's often no quarterbacks kind of arranging it all.
Hmm. You mentioned how the objective of hospitalization is to stabilize, get people, at least so they're not as in as much of an acute crisis.
Sure.
So obviously that can take a different amount of time for everybody. But is there a point at which there's diminishing returns? You know, is there an objective there to make it as short and efficient as possible?
Um, yeah, I mean, there are rules about like essentially using the least restrictive level of care possible. So that might mean, essentially offering someone an oral medication rather than an injected medication. It might mean, offering someone outpatient care instead of forcing inpatient care. And I think that that's followed because most of us don't want to be jailers. Most of us don't want to be taking people's rights away. That's not why we got into medicine. That's not why we got into mental health care. But there are people who are very sick and do need help. Um, Sorry, coming back to your question. Um, is there diminishing returns at times? I would say yes. Um, there's an X factor that gets mixed in, and that's sort of what's jokingly called CYA medicine,
What's
which
that?
is CYA's cover your ass, which is basically no one wants to be the guy or girl or whatever pronoun you choose to use, who sends somebody home and then they do something that is actually dangerous. They actually do hurt themselves. They actually hurt somebody else. No one wants to be that person who made the decision of saying, I don't think they'd need to be here. Let's send them home, and then they actually complete suicide. So what you end up doing is people take cautious steps. They're more conservative in their decisions, and that might come at the expense of somebody's liberties or freedom. They might get kept in the hospital for weeks longer just for the purpose of everybody feeling like this is like calm down.
Mhm. Well, and an extreme form of that may be risk aversion. I don't know, but it seems to be the use of seclusion and restraint, whether that's mechanical or chemical restraint in hospitals. The World Health Organization, of course, has vocally discouraged against this. But in my experience, both personal and professional, it's pretty common. There's very few hospitals that you would find that don't have restraints at the ready, just in case they're needed. So then, in your mind,
Yeah.
what other options do inpatient staff have that don't include seclusion and restraint where it would normally be considered?
Oh, well, that's an entire design element. So like I could speak about, for example, um, I trained at UC San Diego during residency, and the geriatric unit there was very intelligently designed in terms of the environment to help prevent essentially agitation. So like everyone was on bowel regimens because that's what people with dementia get upset about because they can't communicate when they're constipated. The lighting was designed to be specifically at a level of brightness to essentially give light therapy, but it was the ambient lighting. The floors were arranged in a way so that the tiles would go to a certain level and then stop so that people wouldn't wander past the patterns. And there's all kinds of other essential design elements within a standard psychiatric unit in terms of how is somebody developing connections with peers or with nursing staff or techs, which ends up like helping create any kind of preventative relationship, as well as how do you medicate in a preventative model as opposed to doing it to restrain somebody. So if it's about anxiety, helping the anxiety, if it's about psychosis, treating the psychosis. And then, you know, managing every other kind of lifestyle condition that could be beneficial. Do people get adequate exercise? Is the food they're eating actually, soothing and feeling good in their body? Are they getting any level of outdoor time or sunshine? Like these are commonly accepted environmental factors that influence anxiety, depression, everything.
Yeah,
In the 18th
yeah,
century, I think it was, there was a whole movement to essentially take people with psychosis and serious mental illness and put them on in the least restrictive environments, such as on farms, put them to work. And there's some benefits to that because it was the reaction to the really restrictive environment before where people were just chained up literally for their lives in mental hospitals. So I think there's something to that, finding any level of activity, vocational work, involvement for people is all beneficial, as opposed to restricting them as much as possible and punishing them if they don't follow the rules.
Well, and it almost seems very countercultural now, given what we talked about with respect to the immediacy of the system and just trying to manage the immediate presenting concerns. But that assumes some sort of long-term planning. So then the last thing I want to ask you about is around discharge. Some people sometimes are discharged too early for a variety of reasons. Sometimes maybe they feel like they've been in hospital too long and they appeal the hospitalization or they leave for whatever reason. But I'm curious about what a good discharge plan looks like, just in general, to reduce the likelihood that that person might end up back in hospital in a week or a month or whatever period of time it takes.
Yeah, it's hard to give that in a couple of sentences because the discharge plans really vary based on somebody's circumstances and condition. So someone who has no support structures, no family, no friends, and let's say with psychosis is going to need a very different discharge plan than even someone who does have family and psychosis and has been avoiding that. You can have a different level of surveillance and a different approach to kind of medication adherence. But let's say everybody needs some level of follow-up care that they'll realistically be able to follow. Like someone giving lip service to being able to follow up with something is different than otherwise. I would say that they need a appropriate level of step-down care. So if they've needed intensive care in the hospital, just sending them to once a week appointments with their doctor might not be enough. And then really it's about plugging in my opinion, the peer level resources that are available for someone. Are they in support groups, AA, NAMI groups, whatever it might be, which is trying to bring together a community to help support someone's recovery and improvement in health. And I think that we give, like, I've seen hospitals, like, they'll give a printout of something, but there's not really active ways that that's integrated or involved in somebody's care. And I think that that's a huge missing piece, especially around sobriety, especially when people are wrestling with what it means to have this illness. They're fighting it, they're in denial. And finding people who have also gone through that, I think is a key part of integrating this as part of their identity and getting them to be able to work with it.
Especially who've been through it and not only have survived, but have thrived, to really give them a model that they can do it too. But thank you so much.
Absolutely. It can be sources of, sorry.
No, please go ahead. Finish that thought.
I was going to say it can be a source of strength for people when people can own what's happening within them. I think it can be a tremendous source of strength and growth in their life, but that takes help. It's really hard to do that on their own, on one's own.
It is, but I think that with groups like NAMI and that sense of community that can be built in hospitals as well, it's certainly still possible. Thank you so much, Dr. Paul Puri. You're a psychiatrist in Los Angeles, clinical assistant professor at UCLA. Thank you so much for joining me on Modern Minds today. I really enjoyed our conversation.
Me too. Thanks so much.
Thank you so much for joining us this month on Modern Minds. And thank you especially to my guests, Dr. Awais Aftab and Dr. Paul Puri. I hope that you found this episode to be insightful, challenging, and most of all, helpful in informing your own understanding of this sometimes controversial intervention, often controversial intervention, that is involuntary hospitalization. I also hope you go back and check out some of the other episodes that we've done so far. We've talked about deprescribing with Dr. Mark Horowitz. We've talked about back to school with Dr. Pam Epley. Recovery, architecture, teen mental health with Dr. Dan Siegel and Dr. Lisa Damore. Lots of really great experts and names have come on the show, and I look forward to sharing even more with you soon. Every episode is available in both audio and video on Spotify and YouTube. So follow the show on either of those platforms to get notified as soon as the next new one is up. We also have audio-only versions of every episode on all the usual podcast platforms: Apple, Google, Amazon, Audible, iHeartRadio, and more. If you have ideas for future episode topics, or for future guests that I should talk to, people at the leading edge of mental health, then get in touch with me on LinkedIn, Facebook, Instagram, Threads, X, and YouTube at Mark Hennick. That's at MarkHenick. You can also head over to my website, markhennick.com. I look forward to talking with you again next time. So until then, I'm Mark Hennick, and this has been Modern Minds.